Assistant Professor of Radiologic Oncology here at Northwestern Feinberg School of Medicine. He specializes both in genitourinary malignancies and in treatment of brain and spine tumors. He has a focus additionally on stereotactic radiation, novel imaging, and using synergistic approaches with radiation. We're lucky to have him tonight at our ongoing course for urologic oncology updates to talk about adjuvant and salvage radiotherapy for prostate cancer.
Well, I'm happy to to add to this wonderful urologic oncology series that Dr. Ross has started, and I'm excited to hear from other speakers ahead. My goal today is briefly to go over postoperative radiotherapy and to also cover adjuvant versus salvage, the appropriate timing, when do we add ADT, how do we treat in the postoperative setting, so on and so forth. Let me basically start off with a case. This is a patient I treated who was initially seen and basically underwent surgery at a different Chicago academic institution. 58-year-old man with PT3A grade group 4 disease with a focal positive margin. Did very well after surgery with excellent urinary control and largely undetectable postoperative PSA. He was followed closely with serial PSA values, which was undetectable at first, as I mentioned, and then slowly rising to 0.03, 0.05, and then over a time period that I can't recall exactly, it ultimately increased to 0.19, and that's when the patient was referred to me. And I ultimately treated the patient 68.4 grams of radiation using both a combination of IMRT and IGRT, which is image-guided radiation therapy, as well as short-term ADT. He did very well before his first treatment. Had some mild fatigue and hot flashes, but no urinary or bowel issues due to the radiation. And slightly more than a year out, he essentially had normal testosterone and a PSA, which is undetectable, and he's continued to do well since. So using this case as a starting point for our discussion, several questions arise. Should we have treated this patient earlier with adjuvant treatment? Was the salvage approach that we utilized the right one? Should we have utilized androgen deprivation as we did? Was it correct to include the lymph nodes in the radiation field? And here on the right, by the way, you see an example of modern radiotherapy utilizing daily image guidance. Here is a three-dimensional overlay of the patient's positioning from a certain fraction of treatment in comparison with the anatomy that he was planned to from the CT simulation. Of course, for intact gland treatment, the options are more discrete and straightforward. Here are the disease and the pathologic characteristics yield the risk per the DMECO or NCCN risk classification. And from the standpoint of radiation therapy, based off that risk classification, there are an array of options from active surveillance for low-risk disease, of course, in conjunction with colleagues from urologic oncology. I've seen several patients for an initial consultation who strictly fall in the low-risk category, and I usually get them to see a colleague in urologic oncology to go down the pathway of active surveillance, as well as brachytherapy, hypo or standardly fractionated external beam radiation therapy, as well as stereotactic radiation or SBRT. And for higher risk disease, several trials have clearly demonstrated improvements in metastasis-free survival and overall survival with the addition of short or long-term hormonal therapy, depending on the stage. Of note, even recently, there was a paper in a JAMA journal validating a prior RTOG trial using the unfavorable versus favorable Zoom-stag distinction to guide the decision for ADT. But when it comes to postoperative treatment, the picture has always remained a bit vague. For adjuvant treatment with adverse pathologic features, you can consider radiation initially, or you can adopt a strategy of following the PSA. If you do pick a path between the two options, do you add on ADT, and if so, for how long? And importantly, when do you treat? And, historically, this has largely been optimally determined by multidisciplinary input and a nuanced discussion with the radiation oncologist. So when it comes to adjuvant radiotherapy, first let's consider that. Basically, we're looking at we have 4 major trials, 3 large classic older studies, as well as a newer trial out of Finland. And while these trials, with these trials, several questions have remained. How do we determine the appropriate patient selection, and how does one approach observation? Give me 1 second here. Let me just make sure that I am sharing the right screen. Okay. And so we initially, will cover the SWOG trial. This is an older trial, the second smallest of the group, looking at adjuvant RT versus observation for the usual adverse pathologic features. And this is basically a randomization to, observation versus radiotherapy immediately after surgery. Median follow-up of 12.5 years with a primary endpoint of metastasis-free survival. And indeed, the trial was positive for the endpoint that it set out to achieve. There was an improvement in overall metastasis-free survival, as well as overall survival. Important to note, however, as with more follow-up time, the curves did diverge, but we're looking at a smaller and smaller number of patients. And also importantly, this wasn't a clean trial in that, should we really have been observing patients with a PSA above 0.20, which in the modern era would meet the definition of failure. And on this trial, about 32 to 35% of patients had a PSA. So 32% in one arm, 35% in the other had a PSA that was already above 0.20 at the time of enrollment. For the patients who were ultimately treated with radiation, 37% had an objective clinical recurrence, and the median PSA at the time of radiation was 1.0. So not a very clean trial in the context of how we treat patients nowadays. The largest of the group was the URTC trial, which had an N of more than 1,000 patients. Again, looking at very similar, although there were slight differences in how each of the trials included patients, but largely the same adverse pathologic features. And again, a randomization between doing radiation or starting with initial observation. Here again, lengthy median follow-up time. The primary, endpoint here was biochemical progression-free survival. And here we can see that indeed in the group that was given radiation at 10 years, there was a significantly higher number of patients who were biochemically free of progression as compared to patients in the observation group. And again, not something that is very strictly applicable to how we give radiation nowadays. Nearly a third of the patients who got radiated had a PSA greater than 0.20. The median PSA was 1.7. It's actually really interesting if you delve into the details of the final report. In the observation arm, among the patients who actually progressed, only about half got radiation as the first treatment to salvage the progression. So it's really not a trial that we can consider as being a study looking at, observation initially versus radiation in a delayed fashion. Then you go to the German study, the Weigel study, Arrow 9602. This is one of the smaller studies in the group, also looking at a question of adjuvant radiation versus observation. This was, however, unique among the classic 3 larger studies in requiring an undetectable PSA after surgery prior to randomization. And again, here we're looking at, either radiotherapy to 60 gray or observing initially and then proceeding with radiotherapy with increasing PSA values. Again, a lengthy follow-up period. And here the primary endpoint was a composite endpoint looking at biochemical progression as well as a clinical or radiographic progression. And there was a difference in the primary endpoint as the study had specified. However, there's no difference in metastasis-free survival or overall survival, but arguably one could state that it wasn't really powered for this. Also, interestingly, of the 148 patients who were recommended radiotherapy per the protocol specified constraint, 34 refused. So that kind of also adds to the difficulty in the clear interpretation of the results. Then this is the newest and the smallest study, which is run mainly out of Finland. Also basically asking the same question, patients with adverse pathologic features, although notably for this trial, they require that no patient had T3B disease, PSA less than 0.5, N of 250 patients. median follow-up of 9.3 years, randomized again to radiotherapy versus observation, and radiotherapy delivered at a protocol-specified increase in PSA. This is the latest of the 4 trials and the last to be reported. And you can see here, in terms of the primary endpoint, which is biochemical progression-free survival, there was a clear difference between radiation and observation, but maybe because this was a slightly more favorable group that was chosen to be enrolled in the trial, there was absolutely no difference in prostate cancer-specific outcomes or overall metastasis-free survival. We covered all of these trials in a recent review that included Dr. Sain, Dr. Schaefer, as well as Dr. Offenberg, and a few other of our colleagues nationwide from urology and radiation oncology. And basically, we went over the modern landscape of all of the information that has basically emerged in the looking at postoperative radiotherapy. And we also, this is meant to be kind of a review as well as a multidisciplinary input, expert input on how such patients should be managed. And so we covered, here in summary, all of the recently discussed trials that I just went over, the adjuvant trials. And again, here are the criticisms of these trials. But what's important to note once you look at all of the data from a high level view, even with these imperfect trials where patients were being observed for a PSA much greater than 0.20, good portion of the patients that were randomized to observation actually did okay, even at 10 years did not progress in terms of PSA progression. So that, of course, argues the point that, it is important to have a better way to select these patients out. Who are the appropriate candidates who should be observed? Are we overtreating people if we're treating with adjuvant radiation for everyone based just on adverse pathologic features? And that is reflected in the modern use of adjuvant radiotherapy. Here's a graph showing, if you look down here in the orange bars here, who of the patients who have these adverse pathologic features are actually being treated with adjuvant radiation, and that number has largely remained consistent up to 2011. If you go earlier than that, this is a paper by Karen Hoffman looking sort of at the impact of the abstracts, which are shown here with dashed lines, and the actual papers from the EORTC and SMOG trials, and you can see that management of patients postoperatively was not very significantly affected. And that, of course, led to this consensus opinion between the ASTRO and the AUA that patients should be offered adjuvant radiotherapy, but this is not necessarily a categorical recommendation for patients who have adverse pathologic features. And now, that leads to the modern era, and clinical trials that were examining how how a lot of institutions and how a lot of people now have been treating patients in the postoperative setting. And that's really a question of immediate adjuvant treatment versus early salvage treatment. One of the first trials that was presented, this was first reported at ASTRO in 2019, was the RAVES trial, which was run out of ANZUP. So basically, mostly New Zealand and Australia, and RAVES stands for radiotherapy adjuvant versus early salvage. And here, all patients with adverse pathologic features who had to have basically an undetectable PSA were randomized to either treatment with, this is a typo, this should be to 66.6, versus initial observation and radiotherapy, which is delivered at a trigger threshold of 0.2. So if they ever reached 0.2, or if they ever had a value that was higher than 0.2, then that was the trigger for them to get early salvage radiotherapy. What's important to note is that this was designed as a non-inferiority trial, did not actually meet the protocol specified endpoints. The data monitoring committee realized that there was such a low rate of endpoints in both groups that it would take 18 years to fully accrue to the power and the design that the trial was actually put together with. And so the trial was closed early, but did have a lengthy median follow-up of 6.1 years. And during this period, approximately half of the patients in the salvage or the early salvage group met criteria to get radiotherapy. Again, the primary endpoint here was biochemical progression-free survival. But what is notable about this trial is that from a radiotherapy perspective, from the viewpoint of a radiation oncologist, the patient cohort group was actually very favorable. 85% of the patients had Gleason 7 or lower disease in terms of histology, and 67% of patients had a positive margin. Nonetheless, these are still important data for us to go through. In terms of the endpoint of freedom from biochemical progression, there's no difference at all between the adjuvant and the salvage radiotherapy group. And this is basically the the observation group, and freedom from getting radiotherapy. So about 50% ultimately during this follow-up period did get radiotherapy. If you look at the subgroup analysis from the paper now, which has been reported in Lancet Oncology, what's interesting is that there was a trend towards favoring salvage radiotherapy for patients who had T3B disease, which is an interesting finding, but ultimately not statistically significant. Then the largest of the three, early salvage trials was the Radicals RT trial. Also looking at early salvage radiotherapy. Here, interesting inclusion criteria. You had to have one or more of the following features. So T3, T4 disease, which makes sense. Gleason 7 or higher disease, a positive surgical margin. But interestingly, even if you had a pre-treatment PSA of greater than 10, you could be included in the trial. Postoperatively, you needed a PSA less than 0.20. This did have, again, the largest cohort amongst the early salvage trials. And this is a randomization between radiotherapy and observation. Radiotherapy was added on if you had two values greater than 0.1, so two rising values above 0.1, or three rising values in general. This is initially reported in ESMO, and it made waves in the GU sort of onc, global group and global community. Interestingly, what was interesting about the report and now the paper that's been published, the primary endpoint for the trial was metastasis-free survival, but so far they've reported on biochemical progression-free survival, and essentially at with a median follow-up of close to 5 years, approximately 40% of patients met criteria for getting radiotherapy, but only 32% got started. The treatment was at a median PSA of 0.2. The majority of patients got the protocol specified 66 gray and 33 fractions. However, in the UK, with an enthusiastic quest to seek a hypofractionated approach, even in the postoperative setting, a good portion of patients got a hypofractionated postoperative regimen. This trial was run in conjunction with the Radicals HD trial, which is asking the question of, how to best combine hormonal therapy, which is an issue that I will go over in future slides, but basically looking at, radiotherapy alone versus 6 months of ADT or 2 years of ADT. And as you can see here on the graph on the right, nearly 60% of patients who were followed on this trial did not need radiotherapy. But again, what's very interesting about the cohort of patients on this trial, similar to RAVES, the vast majority of patients, we would, from the viewpoint of a radiation oncologist, were favorable. So 83% had Gleason 7 or lower disease, and 63% had a positive surgical margin. Having a positive margin with low Gleason grade disease represents the ideal scenario for us to go and treat the prostate fossa and expect the patient to have a good outcome, which is not applicable to clinical scenarios when we're dealing with higher Gleason score and surgical margin negative disease. If you dig through the supplementary materials from the protocol, what you'd also find is that patients with high Gleason scores, high grade group disease, as well as T3B disease, which is, of course, very, very concerning from a clinical standpoint, represent only 4% of the patients on this trial. Having said that, with the data that have so far been released, there was really no difference in terms of biochemical progression-free survival. Of course, important to note, the primary endpoint of the trial was metastasis-free survival. So even though we have a paper out of published results in the Lancet, that was actually reporting on not the primary endpoint. So we put all of these in a summary tabular format, and you'll see that largely both with raves and radicals with a very similar patient population, there was not a big difference in terms of biochemical progression-free survival. More data are awaited. And with these two trials, as well as the Jatu AFU17 trial, which is a French trial, basically asking the same question. There was a report on a pooled analysis, which is also initially presented in Barcelona at ESMO, and now we have the final report and publication, also I believe in Lancet. This was a pooled analysis looking at all three trials with an endpoint of event-free survival, which is defined as either biochemical progression. This is an endpoint. Excuse me. This is a typo. Clinical or radiologic progression. Start of a new non-trial treatment, death from prostate cancer, or PSA greater than 2 at any time point. And if you look at the pooled data, largely driven by the radicals cohort, again, you see that 85% of the patients in this pooled analysis had favorable Gleason scores, and close to 70% had surgical margins which were positive. What's really interesting is you delve into the data from the AFU17 study. All of the patients actually had positive margins, and they represented a higher proportion of patients with T3B disease. And maybe that's why, as you look through the subgroup analysis of the individual cohorts from the different trials, even though this was not statistically significant, the AFU17 cohort tended to favor adjuvant radiotherapy. As part of this artistic meta-analysis, again, pooling data from all three major trials, looking at observation versus early salvage RT, there was no statistically significant subgroup which impacted their conclusions. And then, just as a quick recap, one of the important data sources that we've looked to for years is the Stevenson nomogram, which basically pulls in data from 1,540 patients from 17 centers. So multi-institutional, robust database with high quality data, and you can punch in the values for all of these different important clinical and pathologic, as well as treatment features to see how patients do. But what we found is, very consistently across the whole data set, is that PSA post-op and pre-treatment is one of the most important, if not the most important, sort of factor which affects how patients do after post-operative radiotherapy. And you can see a clear separation of curves based on PSA values. This nomogram was updated more recently, now with nearly 2,500 patients, again, looking at largely the same clinical, pathological, as well as treatment variables. And now they were able to delve into the PSA, value groups even more. And you can see that, patients who had a PSA less than 0.20 did clearly better than those who had a PSA higher than 0.20. So with those variables in mind, as we tried to put together this JAMA Oncology review and sort of multidisciplinary sort of expert opinion, if you will, Matt Croach had some very sort of strong opinions, and a lot of them, frankly, that I did not think of initially, but I ultimately very much agreed with. So here what Mac did is he took the cohort from radicals and he plugged in, the values, basically the characteristics of the patients on the trial into the latest, multi-institutional nomogram of about 2,500 patients. And you plug in the clinical, and pathologic features of the patients on the trial, you would see that ultimately you're led with a total score that yields a very favorable outlook for patients with these clinical features, meaning a very low probability of developing metastasis-free survival. And this, this is a point that I'll fully credit to Matt Croach, which is a valid point. And he would argue that, these trials answered an important question in how to manage patients who are, probably suited for successful salvage radiation, but it's definitely not ideal in answering questions of whether or not we should be adding on adjuvant radiotherapy for higher risk patients. And this is a point that I fully agree with, and I'll give this credit, credit fully to Matt Roach for this. There are other data that have also looked at this question as to whether or not, adjuvant radiotherapy is important and necessary. This is from Alberto Briganti and Firas Abdollah, a very well-cited paper in European Urology from 2013, basically a multi-institutional European database and nomogram of more than 1,000 patients who underwent surgery and an extended lymph node dissection, and about half, which is optimal for this analysis, got adjuvant RT. And ultimately what they found in terms of outcomes was that the top 3 most important factors for determining cancer-specific mortality included PT3B disease, so invasion of the 7 vesicles, higher Gleason score, as well as lymph node involvement. And then they parsed the data and did basically a further analysis to try and figure out who is optimal to get, who are the optimal candidates for adjuvant radiation, who will benefit from adjuvant radiation. And basically what they found was that if you had any more than one of these factors, then adjuvant radiation therapy really sort of predicted better outcomes as opposed to not getting adjuvant radiation if you're observed. This is a paper in the JCO from 2017, which basically concluded the same factors, but also included Decipher as a factor. This also, I believe, had Abdollah. This also had Ashley Ross's data as well as Ted Schaefer's data. So 512 patients from 4 institutions, of which 112 ultimately were treated with adjuvant radiotherapy. Adjuvant radiotherapy was defined as a PSA less than 0.2, an initial PSA after surgery of less than 0.2, and then moving on to get radiotherapy within 12 months of surgery. If you just, look on face value, the patients who got adjuvant radiotherapy did much better in terms of a 10-year recurrence risk as compared to those who were initially observed. And the most important predictors of cancer-specific mortality was T3B, T4 disease, as well as high Gleason score, lymph node positivity, as well as a higher Decipher score. If you look at those 4 factors, and if you try to figure out who benefited from adjuvant radiation, basically, if you had one or no factors among the 4, then adjuvant radiation didn't really help too much. But if you had 2 or greater number of those 4 factors, then then the patients would benefit from adjuvant RT. I think we are getting to a point where we will, we are now asking this question prospectively. A lot of the newer trials that are being opened nationally via cooperative groups are incorporating Decipher or utilizing Decipher to stratify or to randomize patients. And I think this may be the future. As more of these data, are gathered and analyzed, I think we'll have a better sort of contribution from Decipher, which has always been shown to be prognostic, but is it really predictive? Do we know what to do with these Decipher results? How do we escalate or de-escalate treatment? I think these prospective trials will answer this question. This is the schema, by the way, of G009, which we just recently discussed in our disease team meeting. I wasn't there, but I sort of emailed the rest of the group my thoughts in that this is a very important study, and future studies from the NRG that are looking at similar kinds of design will be very important for us to fully know and to validate how to use Decipher and other genomic information. What about the question of radiotherapy, of hormonal therapy alone? Every once in a while, I see patients who have been managed, post-operatively in the setting of a biochemical recurrence, which is ADT alone. The Japanese ran a very interesting study. This is the JCOG 0401 trial, which we also covered in our paper, which was just recently fully published in European Urology this past year. And this is basically patients who undergo radical prostatectomy, have an initial PSA less than 0.1, with PSA rise to greater than 0.4. The primary endpoint here was recurrence-free survival. 210 patients with a median follow-up of 5.5 years. And basically, patients were randomized to either initially getting radiation alone or initially being treated with bicalutamide alone. If they progressed on the bicalutamide based on a protocol-specified endpoint or threshold, then they were started on Lupron. If they progressed after initially getting radiation, then they were started on ADT. One of the valid criticisms of this trial, of course, is that you're just looking at radiotherapy or hormonal therapy in isolation. Could you have better results when you combine the two? That's an obvious sort of major and valid criticism of this trial. Nonetheless, it's an important trial that sort of really highlights and shows the value of radiotherapy in the postoperative setting. Here, if you look at this blue line, this is the group that got radiotherapy initially, and then if they progressed, then they were started on hormonal therapy. This is the group that got hormonal therapy initially. What's important to note is that the patients who ultimately were treated with radiation, the median PSA was 0.48, which of course is not very reflective of how we, deliver postoperative radiation in the contemporary setting. The goal is to start at lower and lower PSA values. And what's also important to note is even with that, for 32% of the patients who got radiotherapy first, they never progressed. They never needed hormonal therapy. So then that's a nice segue into the other, important question that we have to consider when we're delivering postoperative radiotherapy, and that is whether or not we add hormonal therapy. Do we add on ADT? And if so, what is the appropriate duration? And my goal here will be to really emphasize the high-level prospective trials, good quality trials with lengthy follow-up. I know there's been a lot of information that has come out recently, lots of post-hoc analyses of these trials. I would argue that if the PSA is very low, then maybe one doesn't need to add hormonal therapy. And I'll also delve into that a little bit. But I'm really going to try to emphasize and focus on the higher level, prospective data that should really be guiding how we manage these patients. And here again is the Radicals HD schema, which is a companion trial to the Radicals RT trial, which again looked at observation versus early salvage RT. And this is a trial out of Europe looking at 6 months or 2 years of ADT versus radiotherapy alone. And that is something that we will, eagerly await the results of. So first off, what is the rationale for adding on hormonal therapy? Potentially, ADT is a very important radiosensitizer. It's been shown to reduce tumor cell hypoxia. Oxygen is a very important mediator of radiation effect. And hypoxic cells have been shown across various subsites, various histologies, various tumor models to induce radioresistance. There's good preclinical evidence that adding on hormonal therapy with radiation, hormonal therapy inhibits tumor cell DNA repair after you induce mitotic catastrophe with radiation. It's also been shown to be a neoadjuvant radiosensitizer in lots of animal studies. So there is, a good rationale to combine radiation with hormonal therapy. One of the highest quality pieces of this, this belief is is an older RTOG trial, RTOG 9408, which took patients with intact disease, T1 and T2 disease, treated with radiation plus or minus 4 months of ADT. What was great about sort of how these patients were prospectively followed is that 43% of patients had both a pre-treatment biopsy as well as a post-treatment biopsy at 2 years. And what we found per RTOG 9408 is that at 2 years, the patients who were treated with radiation and hormonal therapy, just 4 months of hormonal therapy, had only a 20% rate of, disease positivity on the biopsy cores as compared to nearly double the rate with RT alone. And this is a really, really important piece of data because the radiation dose is exactly the same. The only difference is 4 months of hormonal therapy. And so if we go through a few of these trials asking this important question, there's a Jatu AFU 16 study where everyone got salvage radiotherapy. Basically, patients had to have an undetectable PSA first with PT2 or greater disease, and then if the PSA rose to the range of 0.2 to 2.0, excuse me, 0.2 to 2, the patients were randomized to either getting radiation alone or radiation with a 6-month duration of ADT with 2 shots of Zoladex. Median follow-up was 5.3 years. And this is the initial paper from that trial with a very significant difference in terms of progression-free survival at 5 years. In 2019 at ASCO, there was a report showing now that with more lengthy follow-up, there was not only a difference in PFS, but also a difference in metastasis-free survival. And then we, of course, got the final report, at the end of 2019, which is published in Lancet Oncology, showing that was indeed the case, not just a benefit of PFS, but also metastasis-free survival. There has been some criticism. There was an editorial response to this paper. If you delve into how the protocol was designed and how these data were collected, basically, they did not have cleanly and prospectively captured data on metastases. So it was almost in some ways, according to some criticism, basically a retrospective review, if you will, of all the data that was gathered during the length of the clinical trial. But it seemed to be done in a high quality manner. So there's lots of there's been some infighting between groups who say this is just a retrospective portion of a well-designed prospective trial. There's some people who believe these results at face value, and there's debate over how much stock to put into this. But clearly, there's a benefit to adding short-term ADT with post-operative radiation. Then there's, of course, the Shipley trial, RTOG 9601, which is looking at giving 64.8 gray with a very lengthy follow-up period. And here patients were uniquely randomized to doing either high-dose bicalutamide or were just given placebo, so it was a placebo-controlled trial. And basically what we found was that over a very lengthy follow-up period, after 12 years, there was an improvement in overall survival, a very significant difference in the rates of metastatic disease, so 14% versus 23% if you did not get hormonal therapy. Importantly, when they went back and they looked at all of the different subgroups, of course, with the caveats of doing any kind of a post-hoc subgroup analysis, the most important variable was the PSA at the time of treatment. This variable had an interaction with all the other clinical and treatment and pathologic features. And basically what they found was that regardless of how you sliced the data, for patients who had a PSA less than 0.7, there was no major difference in terms of outcomes. But for higher and higher PSAs, there was clearly improvements in outcomes. Also important to note is that the median PSA on this trial was 0.6, so it's not very reflective of how things are done in the modern setting. And again, it's important to note that PSA matters. Again, this is the Stevenson nomogram here on the left, and this is the update from the same nomogram with more patients. And you can see very clearly that the PSA at the time of treatment with radiation makes a huge difference. In that context, so if you remember this slide, very recently there was a paper that was published in JAMA Oncology, and this was after we saw the presentation at Astro last year. Excuse me, not last year, in 2019. But basically, they went back and looked at all the data from 9601, and what they found was that indeed there was an improvement in overall survival as well as distant metastatic disease when you're dealing with patients who had a PSA of 0.6 or greater. But actually, as you looked at patients who had lower PSA values, there was actually maybe a decrease in overall survival, and that may be driven by other cause mortality from the high dose bicalutamide. I personally, this made a lot of waves in the radiation oncology community. Some people saw these data and they swore off never using hormonal therapy in the setting of low PSA values. I think that's personally, from my viewpoint, I think that's a very simplistic view of how to consider when to bring in ADT. I don't think you can look at one variable in isolation. I think the PSA clearly, from multiple data sets, has been shown to be a very important determining factor, impacting how patients do after they're treated with postoperative radiotherapy. But in terms of, using that as a single factor to determine whether or not you give hormonal therapy, I think that's likely a too simplistic view of all of these variables having an impact on outcomes. And then finally, RTOG 0534, which is also known as SPORT, is the largest trial looking at this question from the RTOG. Here, patients had to have at least a PSA of 0.1 after surgery, and they were pretty permissive in terms of how much dose you could give. Median PSA was 0.34. A very large number of patients. Follow-up of 5.4 years when this was presented at ASTRO 2018. And basically, this is a trial that did a three-way randomization between prostate bed radiotherapy alone, prostate bed radiotherapy with 6 months of ADT, and prostate bed radiotherapy with 6 months of ADT, as well as lymph node RT. And what they found was that the more treatment you added, the better people did in terms of failure from progression, which was a composite endpoint, which included either a frank clinical recurrence or biochemical progression. And basically, if you added lymph node RT as well as short-term ADT, those patients did better than the other two groups. There was actually an improvement in terms of rates of distant metastases if you look at arm 3 versus arm 1. Importantly, to note, if you look at patients who were treated with IMRT, so modern radiation therapy, in terms of GI and GU toxicity, there was no difference. The only difference was in mild bone marrow suppression, grade 1 bone marrow suppression. Of course, when we add on a pelvic nodal field, we expect the bone marrow to be mildly affected for a few days to a few weeks, but we expect the bone marrow to recover. But in terms of GI and GU toxicity, there was no difference. And then when you look at, the value of ADT and nodal therapy, here what they found was that while the three groups were clearly different in terms of outcomes, if you looked at patients who had a PSA less than 0.34, so there was a clear difference if the PSA was above 0.34. If you looked at patients with a PSA of less than 0.34, again, 0.34 was the median PSA value of the patient cohort. What you found was that there was no significant difference between arms 3 and 2. So basically, arm 2 included prostate bed radiotherapy with ADT. Arm 3 added on lymph node RT. So basically what this is trying to argue is that if you have a low PSA value, then perhaps there isn't a lot of benefit to adding on a lymph node field. Of course, this is a post hoc analysis. We don't have the final results of the protocol yet. So I don't know if you could take this as gospel, but it's interesting. The PSA value might impact the benefit of nodal radiation. But again, if delivered in a modern way, with intensity modulation and with daily image guidance, there is no real difference in terms of GI and GU toxicity. This is basically how radiotherapy and hormonal therapy are usually synchronized per the RTOG approach. Basically, all of the RTOG trials have used something similar. The patient gets started on ADT as part of CAB. You get bicalutamide lead into the first Lupron shot. And approximately 6 weeks into that is when you would get your CT simulation. And then 2 weeks beyond that is when radiotherapy would start. During this whole period, per 0534 and per a lot of the RTOG trials, you would actually continue bicalutamide, get your second shot during the course of radiotherapy, which would then sort of lead to about 2 months of adjuvant hormonal therapy beyond the radiotherapy. There have been some data recently in the JCO and other journals, from smaller trials showing that maybe there's no difference if you do neoadjuvant versus adjuvant or concurrent ADT, especially in the postoperative setting. In the intact setting, of course, if you start off with neoadjuvant ADT, it's helpful to see to see the gland shrink. If they have nodal positivity, you see nodes shrink as well, which makes it a little easier to deliver, nodal boost and a comprehensive nodal field with gland radiation. In the postoperative setting, one could argue, well, that's not a very compelling argument. There's recently a meta-analysis showing that, from pooled trial results, doing adjuvant hormonal therapy may actually lead to better results than neoadjuvant. Of course, that's hypothesis generating. It's an interesting, paper in the JCO. But so far, this has been the RTOG approach. There have been some data looking at dose escalation. We have very robust, data looking at dose escalation in the intact setting. Well, of course, people were then asking, is there any benefit to increasing the dose in the postoperative setting? Chris King at UCLA has done some modeling from pooled data from different studies. This is a very well-cited paper from the Red Journal. At least according to this theoretical, model, there's a 2% gain in a recurrence-free survival per gray of radiation that's added on, but that has not really panned out in clinical trials and large sort of studies looking at databases. This is a paper from Sloan Kettering where they looked at patients who got 70 or higher gray of radiation versus less than 70 gray. There's no difference at all. This is a trial out of China from Peking University, a small trial, 144 patients, basically locally advanced disease, PSA at least 0.2. Most of the patients on this trial got lymph node RT, and either in an adjuvant fashion or if doing salvage radiation, it was a flip of a coin between 66 gray versus 72 gray. And basically what we saw was that there is no difference with a median follow-up of 4 years. The authors argued in this Red Journal paper that came out last year that if you look at patients with Gleason 8 or higher disease, there was a difference, but just look at the this small number of patients. So I'm not sure if you could really hang your hat on that. There is a Swiss trial, the SAC 0910 trial, which has been sort of underway for a while, looking at patients with a rising PSA being referred for and treated with radiation either to 64 gray versus 70 gray. We've had some preliminary results in terms of toxicity, which I'll show you next. But important to note, if any of you are attending GU ASCO, we'll have an update from this trial just next month in a few weeks. So basically, what they found was that even if you are giving, higher doses of radiation, not very or very significantly high, but basically if you're going to 70 gray as opposed to 64 gray, there really wasn't a major difference in terms of toxicity or recovery from incontinence. So basically this is my last slide, and I'll be happy to open up to questions. This is my approach. This is sort of my interpretation of the data, where I heavily rely upon run high-level prospective studies, well-powered studies where we have final results. And there are, of course, areas where there's controversy and we await further data. But basically, I would say that even though technically, if you look on face value, raves did not meet their pre-specified non-inferiority, endpoint. Radicals, we don't have any data on the primary endpoint. We just have data on biochemical progression-free survival. And there's a Duke study, which I didn't show here in the slide deck, actually also had such few events that they closed it due to futility. So none of these trials in isolation, met their endpoints as designed. Having said that, given the large N, the conclusions holding up, in a pooled analysis, I personally, even though as a radiation oncologist, I love to treat and see good outcomes in my patients, I actually favor more of an early salvage approach as opposed to an adjuvant approach, with the exception that, these patients especially, from multiple data sources, including the large retrospective, pooled data papers that I presented and from others, there's so many, sources that would support early adjuvant radiotherapy for patients with these very severe features, pathologic features of having, T3B disease, no positivity, as well as Gleason 8 disease or higher. I would say these two for me are very important in recommending adjuvant radiotherapy. If I see a gentleman who has T3B disease or node positivity, almost certainly I'm in favor of adjuvant radiotherapy because I think that will make a difference. If I have a young patient, a young man with Gleason 8 or higher disease, I strongly consider it. If we're going ahead with adjuvant radiotherapy, almost certainly with these adverse pathologic features, I'd be adding hormonal therapy. And if there's node positive disease, I'd be requesting my colleagues in medical oncology to see if they can get, the patient started on ABI as well. Everyone else, I would largely approach in an early salvage manner. For patients with lower PSA values, I almost always recommend short-term ADT 4 to 6 months. For dealing with a PSA that's less than 0.5 to 0.7 range, strongly advocate PET, a PET Axamin, or hopefully in the future PET PSMA as it becomes more widely available. Who do I think of as being candidates for no hormonal therapy? Very low PSA, especially in the conjunction of surgical margin positivity, patients who are much older, and especially when the risk of ADT is high. So if you have someone, with a low PSA doubling time, who were in their 70s with a, Gleason 7 disease with a positive margin, with a very low PSA, where I'm not sure if adding on ADT is going to be all that beneficial. Frankly, one could argue you could just follow this patient for a while and still not expect an impact on their mortality. Those are the patients where I would at least consider no ADT. I would talk to the patient about, not utilizing hormonal therapy. But almost for everyone else, I go down this pathway of at least incorporating short-term ADT. As we pointed out in our paper, and as I've shown you with the prior, higher level studies, in terms of good quality prospective data, we've never been able to prospectively identify, we've always found a benefit to adding on ADT. We've never been able to prospectively identify for whom we should clearly omit ADT. All of that push is from post hoc analyses, and as we know, those can often be completely wrong, and it's very important to take those with a grain of a grain of salt. And then finally, for PSA 0.7 or greater, there I would strongly advocate for 2 years of ADT. There are trials underway looking at this group to see if more needs to be done. Obviously, if they have PET avid foci elsewhere, those are the patients that I would strongly consider, especially if we're dealing with limited number of lesions, adding on SABR or SBRT to each individual lesion. There's a trial that the RTOG Foundation has underway that we tried really hard to open here at Northwestern, but we ultimately could not get through the contract negotiations. Basically, this is a trial looking at anyone with a PSA of 0.7 or higher treated in the postoperative setting. It's 2 years of ADT plus or minus enzalutamide. So I think we're going down the road of treating these patients more aggressively with better systemic agents. And I will pause there.